Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's December 2024 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. Our editor's choice is a review article entitled Post-Pulmonary Embolism Syndrome, a Diagnostic Dilemma and Challenging Management. It is authored by Dr. Kajal Shah from Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire, and colleagues from the University of California, San Francisco Health in San Francisco, California, Mayo Clinic in Rochester, Minnesota, and Brigham and Women's Hospital in Boston, Massachusetts. The acute complications, morbidity, and mortality that attend acute pulmonary embolism are generally well recognized. Less well recognized is a post-pulmonary embolism syndrome that may afflict up to 50% of patients who experience acute pulmonary embolism. This syndrome, comprehensively and expertly reviewed by Shah et al., is characterized by unresolved or escalating symptoms, loss of functional capacity, and cardiorespiratory compromise, diagnosed at 6 months or later after an episode of adequately treated acute pulmonary embolism. This syndrome is heterogeneous, comprising 2 subsets that stem from chronic thrombus formation. These 2 subsets include chronic thromboembolic pulmonary hypertension and chronic thromboembolic disease. Chronic thromboembolic pulmonary hypertension is defined by elevated mean pulmonary artery pressure and pulmonary vascular resistance. Chronic thromboembolic disease exhibits normal hemodynamics at rest. However, the stress of exercise in chronic thromboembolic disease may elicit pulmonary hypertension, right ventricular arterial uncoupling, or ventilatory compromise. A third subset, not originating from chronic thrombus, is itself heterogeneous and may reflect deconditioning, pulmonary infarction, or right ventricular dysfunction. Shah et al. Discussed the underlying epidemiology of post-pulmonary embolism syndrome, as well as its risk factors and predisposing conditions. The authors then delineate how the pathologic events of acute pulmonary embolism may evolve into chronic thrombus formation, and how abnormal thrombus remodeling alone or in conjunction with vasoconstriction, small vessel vasculopathy, and inflammation may culminate in pulmonary hypertension, right ventricular dysfunction, and other features of the post-pulmonary embolism syndrome. Shah et al. Review the spectrum of clinical features of post-pulmonary embolism syndrome and how the diagnosis of this syndrome is reached. As regards the latter, the authors discuss the roles of right-sided heart catheterization, cardiopulmonary exercise testing, and imaging modalities. Imaging includes pulmonary angiography, transthoracic echocardiography, and ventilation perfusion scintigraphy. Management of each subset of the post-pulmonary embolism syndrome is fully reviewed in conjunction with the aid of a very helpful flow diagram. Interventional approaches that may apply to chronic thromboembolic pulmonary hypertension and possibly chronic thromboembolic disease, such as pulmonary endarterectomy and balloon pulmonary angioplasty, are also outlined. Shah et al. Reviewed the indications for anticoagulation, pulmonary rehabilitation, exercise therapy, and assorted therapies that specifically apply to chronic thromboembolic pulmonary hypertension. For this latter subset, lung or heart-lung transplantation may also be a consideration. Finally, the authors point out ongoing studies that are examining fibrinolytics and advanced therapies in the prevention of this syndrome. Shah et al. Are to be commended for this informative an in-depth review that spotlights a major syndrome that is insufficiently recognized. Our first highlight article this month is a letter to the editor entitled Ischemic Monomelic Neuropathy After Dialysis Access Creation Requiring Emergent Fistula Ligation. It is authored by Dr. Talene MacArthur and colleagues from the Division of Vascular and Endovascular Surgery at Mayo Clinic in Rochester, Minnesota. The endogenous arteriovenous fistula is generally the preferred permanent access for maintenance hemodialysis. The premise underlying arteriovenous fistula creation is that the diversion of blood from an artery to a neighboring superficial vein leads to markedly increased venous blood flow rates needed for adequate solute clearance by hemodialysis. Additionally, the heightened hemodynamic forces acting on the vein after fistula creation would promote venous outward remodeling and maturation, as well as toughening of the vein such that the fistula vein can be intermittently punctured by 2 needles as is required for chronic hemodialysis. Complications of fistula creation include failure of the fistula to mature to functionality, the need for an intervention to promote fistula maturation, or the complete loss of function in a once usable fistula. Other complications originate from the very act of shunting of arterial blood to the vein. Insufficient blood supply to the limb distal to the fistula may promote limb ischemia, which is manifested as the Steele syndrome. This syndrome may occur in up to 8% of patients after fistula creation and is variable in its severity, with symptoms ranging from discomforting pain, numbness, a cold sensation, and tissue discoloration to frank ischemic tissue necrosis. A rare manifestation of the Steele syndrome occurs when nerves in the ipsilateral extremity are specifically targeted and rendered ischemic after fistula creation, such that a motor sensory neuropathy results. The occurrence of such ischemic monomelic neuropathy is tellingly illustrated in a letter to the editor by MacArthur et al. The patient presented to the ER with acute pain and the symptoms and signs of an acute neuropathy involving the left hand, 2 days after the creation of a radiocephalic arteriovenous fistula in the left upper extremity. On the night after fistula creation, the patient experienced pain in the left hand and thereafter worsening sensory motor deficits. The diagnosis of ischemic monomelic neuropathy was expeditiously made and the fistula emergently ligated. By the second post-operative day, the symptoms and signs of the neuropathy essentially had resolved, except for mild numbness. There are acute emergencies involving an arteriovenous fistula. These include acute loss of thrill, rupture or impending rupture of an aneurysmal arteriovenous fistula, arteriovenous fistula infection, heart failure, and a Steele syndrome that threatens tissue viability, among other emergencies. This case presentation by MacArthur et al. Highlights another such emergency involving an arteriovenous fistula, the rare but potentially irreversible complication of ischemic monomelic neuropathy. Our second highlight this month is an original article entitled Characteristics of an Older Adult Population Without COVID-19 Infection in a Southeast Minnesota Community. It is authored by Dr. Robert Pignolo and colleagues from Mayo Clinic in Rochester, Minnesota. During the recent COVID-19 pandemic, controversies emerge and still persist regarding public health policies and recommendations that are intended to interrupt the spread of the disease. Pignolo et al. Undertook a cross-sectional survey-based study nested within a larger prospective cohort study of more than 2,500 community-based adults age 50 and older to determine socio-demographic characteristics, behaviors, and beliefs that are associated with the occurrence or not of a COVID-19 infection. The absence of a COVID-19 infection was ascertained by either having tested negative for COVID-19 or never having the need to be so tested. The findings demonstrate that a reduced likelihood of having COVID-19 was associated with COVID-19 vaccination, as well as certain health behaviors. These behaviors include staying at home as much as possible, social distancing, wearing a face mask in public, not congregating to worship, not going to gyms, and avoidance of social gatherings. Moreover, beliefs in effective COVID-19 protective measures and modes of transmission were less likely to be associated with a history of COVID-19. These beliefs included the virtues of wearing masks, hand washing, the use of a hand sanitizer, avoidance behavior in public, and seeing a healthcare provider for possible COVID-19 or exposure to someone with COVID-19. In discussing their findings, Pignolo et al. Point out the incontrovertible evidence that vaccination promotes natural immunity, while the behaviors and beliefs attended by a lesser likelihood of a history of COVID-19 are readily understandable because COVID-19 spreads by exhaled aerosol droplets. The authors conclude by emphasizing the relevance of these protective factors for healthcare policies and initiatives intended to interrupt the spread of future COVID-19 variants. You can access these highlights and editor's choice articles free of charge during the entire month of December. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you will find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the links in the gray bar at the top of our homepage from the Connect menu to follow us on Facebook, X, formerly known as Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the home page as well as through iTunes. As always, we greatly thank you for your interest in and support of Mayo Clinic Proceedings. We hope that you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel, www.youtube.com Mayo Proceedings, or journal updates on Facebook, www.facebook.com Mayo Clinic Proceedings. You can also follow us on X, formerly known as Twitter, available at Mayo Proceedings. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This content is copyrighted by Mayo Foundation for Medical Education and Research, published by Elsevier Incorporated. All rights are reserved, including those for text and data mining, AI training, and similar technologies.